to connect our Vermont child health experts to leaders of Vermont's early childhood programs, all working toward healthy Vermont children. We so appreciate you all taking the time. We know that many people are interested in these topics and are not able to join us at 1 o'clock. And so we are recording it, and we will send this out via the Let's Grow Kids systems, as we always do. Everyone is muted, and we are happy to take your questions in the chat box. So go ahead and submit them throughout the time, and Katie's going to try to make sure there's time at the end to address some questions as they come up. But on that note, I just want to hand it over to Katie from the Vermont Department of Health and have her get us started.
Hello, everybody. My name is Katie Luffel. I'm a nurse with the Family and Child Health Division, and I am here with my colleagues from the University of Vermont Medical Center, University of Vermont Lerner College of Medicine, and the Department of Health here. Luann, if you want to share the agenda, I'll just go quickly over the agenda for today. Here we go. So today we're doing the introductions, which I'm doing right now. Brina's going to help with as well. And then we're going to have Dr. Becca Bell present some of the latest information around what UVM is seeing and the general pediatric updates. And then we're going to have John Davey present on epidemiology, and then the immunization department. I'm going to do a little bit on directing families for testing kits, and then we will be taking Q&A. So anything you put in the chat, we'll have a chance to address there. If we have time at the very end, I have some new safe sleep and car seat safety resources to send to you guys. If we don't have time to talk about it in the meeting today, then we will just send those out separately for everybody, so I'll access to that. Anything we don't get to today as far as Q&A, if it runs over, we will collect all those questions and answer after, as we have before. So don't worry if your question doesn't get addressed during this meeting. And now I'm going to pass it over to Brina.
Thanks, Katie. Hi, everyone. I'll just go ahead and introduce myself in case some of you don't know me or are new. I'm a pediatrician. I had a big role during the pandemic with all of you in the school and childcare branch of our response, and now I work at the Vermont Child Health Improvement Program. What I really wanted to say before we introduce Becca and the rest of the team is that here we are again, January, deep in a respiratory season that Becca's going to really come alongside and share with you, because she is in the clinical care and certainly seeing the sickest of Vermont's littlest citizens. But I did want to just acknowledge we remain so committed to you, and this team that Katie leads us and assembles our expertise and thinking ahead of these webinars, we will do for as long as they're of value to you. And the reason we want to keep showing up for you is because we are so acutely aware of what it's like for you out there, and how important your role is in the lives of children. So I'm just so heartened every time I come on and feel that your passion to keep kids healthy and safe, and that the health department team and Becca and Brina really representing clinical care, but also American Academy of Pediatrics, we're just committed to being with you for as long as you need and want. So with that, I'm going to turn it over to Becca. Becca is a pediatric intensivist, but she's also just immediate past president of American Academy of Pediatrics. And in her role as intensivist, that means that she works in the ICU. So she's the best person to help us understand what's happening out there in this terrible respiratory season. And I'm going to turn it over to her, and then you'll be hearing from John and Katie as well, and we'll introduce them as they come on.
Thanks, Brina. And I echo what Brina says. We are here for you for as long as you want. I think what people find helpful is just to get info about what's happening, like what's happening in the hospital, what are we seeing in the clinics, what are we seeing in the ICUs, like what's upcoming, what can we expect? Because you all we have limited time to be with families and to talk to families, and you all are seeing families every day and they have questions for you. And it's nice to be in the know and to get some insider information. So I'm going to present some insider information about like what things look like right now and what I expect them to look like over the next few weeks and months and what can be done. Okay, next slide. So I like to have graphs and charts and data, and I think they can sort of paint a picture. I have a few graphs, and and I'm going to spend a little bit of time on this first one. So what you're looking at right now are rates of hospitalizations for children under 4 and under nationally. So this is not just Vermont or not just the Northeast, this is nationally. And it includes a few seasons, and it's specifically for RSV. RSV is the most respiratory syncytial virus, which I've talked about here in the past, so I won't go into too much detail. Actually, if you go back to the last one, yeah. I can talk about it more if you have questions, but this is the thing that's sending most common reason that kids go to the hospital. It's the most common reason kids get admitted to the ICU. This was true before the pandemic. During the pandemic, we didn't really see much of it, and now we're seeing it again. And we're going to talk a little bit, Katie's going to talk more about some new products available that will hopefully, especially in the future, help stem the tide of this every year. So let me orient you to what you're looking at. So you're looking at the bottom, if you can read it, it's like the months starting in October through September, because oftentimes respiratory viral season starts in the fall, especially in the South. For us, it's really in the winter. But if you look at the purple graph, that is a typical RSV season. So these are hospitalizations. Kids are sick enough to need to be in the hospital. And typically it's like a 3 to 4 month season, and it happens every year. And for us, we're usually in Vermont, since we're up north, we're shifted a month or two. So in this graph, this purple graph, it sort of shows November, December, January, February as being the busiest months. We sort of are shifted about 2 months. So typically we're busiest February and March with RSV, but the shape of the graph is the same. And it's always the same, where we have no RSV. And then for a few months, we have a lot of RSV, and then we have no RSV again. Okay, so that purple is a typical year. I took out the years of the pandemic because we really didn't see any RSV. And then that green that you see, that's last year. And remember, it came earlier, so it was shifted earlier. And in Vermont, we saw it really in October, November, December, a little bit in January. And it was a high peak up and a quick drop down. And so you can see why we were very stressed. There was a lot of news articles last year about like hospitals, children's hospitals setting up tents and not being able to admit all the children that needed to be admitted to the hospital, because again, these are hospitalizations. So we had a lot of hospitalizations last year. This is true in Vermont too. And we had this sort of like, it was more of a peak. So we had a lot all at once, and then it kind of, then disappeared. Really, for us, we didn't really see RSV past February last year. Okay, so that was last year. And the reason why we had so many is that we had a lot of 2, 3, 4-year-olds that were getting RSV for the first time, and usually the first infections are, worse. So we expect to start seeing a more typical pattern. So the red is what we're seeing this season. Again, this is national data. And so I just want to caution you, and I'll show you some Vermont data, that like dotted line is sort of what they think is happening nationally. We have not peaked yet here in Vermont. We're later, but in the South, they have peaked with RSV. But you can see it's sort of a more similar pattern where it's like not as peaked, but it is a little bit of going to be like a wider curve. So it's probably going to be like around like a 4-month season, 3 to 4 month season. Next slide. And it's a bit earlier than pre-pandemic timing. Okay, so then like what about, that was national data, which is in that, the southern states have already peaked. So let's look at the state that's closest to us that has this hospitalization data, and that's New York State. And this is sort of showing the different years. So the 2019 RSV season, the 2020 RSV season, we didn't really have 2021. 2022 is weird. We had this huge 2023 last year. And then this year, the New York data is a little uncertain. I don't think it's peaked yet. So, but you can see it kind of is probably mimicking like a pre-pandemic season. Next slide. And this is Vermont. So these are not hospitalizations, but these are positive tests in RSV tests. And that big thing in the middle, you probably can't read the weeks down below, but that was last year. So last November, October, November, December, and you can see where we are, where we're on our way up. We haven't yet come down. However, when I looked at the other states, even states in southern New England have started to peak. So I don't think we're going to get as high as we did last year, but which is to be expected. But remember, even after we peak, we still have another like month or two of RSV. So that's all to say that RSV is the thing that's, it's here, it's around, everyone's getting it. And kids in your age group, the kids that you care for and that we care for get the sickest from it. And so this is going to be a big burden on families right now and on pediatricians and hospitals. Next slide. So, and I'm available to answer questions too about this, but here are the things we can do. And we've got immunization experts here to talk more about this, but flu shot for everyone over 6 months. It is not too late. I will say that I've seen a little bit of flu A so far this season. I don't think we've really reached our sort of peak for flu A. And then remember, there's always later on in the season, like a flu B bump. And that's all to say that it is totally worth getting a flu shot now even if you haven't. It's not too late to get a flu shot. And we do see, I've had a couple this season, very serious complications of influenza, like we do every flu season in the PICU. So, kids can get the flu and then they can get like bacterial superinfections in their lungs and necrotizing pneumonia, and they can get even things like encephalitis from the flu and other stuff. So it can be really serious. So 6 months and above, flu shot. And then we'll talk more about the RSV vaccine. But I do want to just put into context for you all the kids that are the sickest that need to be put on ventilators for RSV, which we have a bunch of babies right now who are on ventilators in the PICU. They are very young and they tend to be weeks to a couple months old. So we talk about especially RSV in kids under 6 months, but especially those that end up on ventilators oftentimes are under 4 months, 3 months, 2 months, a few weeks old. So those may or may not be the children directly in your care, but they're probably the siblings of kids in your care for sure. And so the very most common clinical scenario of the sickest RSV kids that we see is the 3-week-old who has a 2-year-old in childcare, right? Like that's the common scenario. So like they bring someone has a baby, it's the middle of RSV season, they bring the baby home, and they have older siblings who are going to childcare or going to school, and they bring RSV home and they give it to the baby, and the baby gets really sick. So thinking about those folks in your community, if you have parents who are about to give birth, I would let them know about the RSV vaccine for sure, because they can get it between 32 and 36 weeks gestation through the end of this month. And that will help. The mom makes antibodies, and then she'll pass it on to the fetus. And so when the infant is born and it's in the midst of RSV season, they've got some antibodies from the mom. And then the other option, which we'll talk about a little bit more, is the RSV shot, which is directly an antibody. And we are giving it to infants like right after. The infants can get it right after birth. And we have some supply issues with both of these things. And so it's a little bit hard to find. And but we'll talk a little bit more about where you can talk to families about this. And certainly we'll be coming back next fall for sure to talk about this and how we can especially get your population protected from RSV, because it's a rough RSV season. Is rough for everybody. Next slide. We'll share some resources that you can share with families. This is for families. So we've got some resources from Healthy Children. Last year, because I got so many questions about RSV, it was just like endless. I made some TikToks for families, and I have the TikTok handle and then also an Instagram account just about RSV stuff. I haven't made any more this season, but I've actually seen it getting shared recently, I think, from people finding it. So I might make more. If you find them helpful to share with families, let me know. I can make more, but just little videos for families so that they have information about like when to seek care what are some home remedies like nasal suctioning? How do we prevent it? It's washing, right now it's washing hands, and then getting the vaccine and the antibody if you're able to, and what the signs and symptoms look like. So hang in there. I think we're really on the upswing where I think we're about to peak with RSV, and this is like the worst thing for kids in your age group. And then, we still have other viruses that are going to be around, which we can talk about later in a couple of months. But this is really the hardest season for everybody. And I'll stay on for questions.
Thanks, Becca. I think I'm the MC. Maybe Katie can do it with me, but should we go next to Katie or John? I guess John Davey from the epidemiology team at the health department, also here for you as long as you want. Take it away, John.
Thanks, Brina. Are the slides up, or should I share? Sorry, I can't see. Oh, great. Okay, awesome. Thank you so much.
Is this yours? That's Katie's. Is that yours, John?
That is me. Oh, I sent you. Yes. All right, we can go ahead. Yeah. No, that's Katie. Sorry.
I think John had a separate.
I have my own screen up, and I was looking at my own screen. That's great. I'm really good at this. So I'll introduce myself while we get this figured out. My name is John. I've met with a lot of folks here before. I am the COVID-19 epidemiologist with the Department of Health Infectious Disease Epidemiology group. I am not only going to talk to you about COVID today, though, fortunately, but I just want to, emphasize that coming out of the last couple of years, we saw sort of an unprecedented amount of attention to infectious disease epidemiology. And I think, this is a year where we're really seeing, particularly for this population, COVID is not the main story this year right now with this population. And I think we want to make a couple points today. One, oh great, that's me. One is that we can leverage kind of what the public, what our families and communities have learned about infectious disease prevention in the last few years to kind of make the other diseases a little more manageable for us. And then I also just want to clear up what it is that the health department sort of wants and expects from our community partners going forward. So we can go on to the next slide. There's a few different, I think folks got used to a lot of different data sources regularly coming in with COVID-19. And what we have to look at in terms of epi data for other diseases is a little different. But a really nice point of data that we have is looking at emergency department visits. And we can look at those by what type of illness is presenting. So this is the Vermont specific respiratory disease activity in terms of who is showing up in emergency departments. And we see COVID has kind of leveled off, but like Dr. Bell highlighted, we're really starting to see the RSV take up as well as the influenza. Go on to the next slide, please. What can I do that? Okay, so in terms of what's going on with COVID still gets a lot of media attention. We've been steadily trending up for a while, but we're still pretty low. Where we see its impact is really in, long-term care facilities, skilled nursing facilities, a lot with this sort of older populations. But we are seeing that pick up, and it does sort of add to the burden of healthcare facilities. So it's worth keeping in mind even with this population. Can we go on to the next slide? So our case data isn't what it used to be when everyone was going and getting tested and all that data was coming through, but we still do get, every time a healthcare provider administers a COVID test, whether that's a PCR or an antigen test, we're getting an electronic report about that disease. So if a kid is sick enough to go into care, be seen with the doctor, or is otherwise in care and showing symptoms, we're going to get that test result. What I want to highlight here is really how different things are for the 0 to 9 group. And again, we know this isn't all the cases, but these are kids who are getting into care. We see relative to earlier pandemic peaks, even well into 2022, when there was already a lot of at-home testing, we're just not seeing a lot of healthcare administered positive COVID tests among the youngest population. Next slide, please. We do have a regular, so here's, that got moved around, I'm sorry. Oh no, this is the RSV wastewater. One of the nice things we've seen with the, no, we are going to go back to this slide. Okay. We go back to the flu side. Sorry, I just want to highlight something there real quick. My colleague Hillary produces a weekly influenza-like illness report. It's not showing up there, but one of the things I want to highlight is, like we talked about earlier, it is increasing in Vermont. It's still in the what gets categorized as the low range, but it's still increasing in Vermont now. So we probably haven't seen that peak yet. And one of the things I want to highlight, and unfortunately the graph isn't showing up, but about 1/3 of patients that we see going into emergency visits with influenza are under the age of 5. So, unlike COVID and more like RSV, flu is still a pretty serious risk for this population. Again, these are kids showing up in emergency departments or urgent cares with influenza-like illness. So unlike with COVID, where we're really not seeing the volume of visits being driven by COVID per se in this population, we're still really seeing this with flu. And then we can go on to the next slide for the one of the nice things about how our public health infrastructure grew a bit during the pandemic is we have all these wastewater indicators available to us. And to kind of emphasize what Dr. Bell was showing us, we've seen an increase in Vermont around this time. Sort of, I would say this is a bit ambiguous as to whether we're sort of peaking now or it's possible that would continue as well. But we've definitely saw this later season peak in Vermont that was seen in much of the rest of the country. So I think it's still not clear yet what the direction is. So I really want to emphasize sort of continued vaccination, continued prevention practices towards RSV. Next slide, please. Thanks so much. So, to highlight, all of these diseases are circulating right now. We're not seeing some of the massive peaks we saw in recent years with COVID and RSV, but they're all going now. It's putting a big burden on healthcare providers. And again, want to emphasize that while COVID has been the point of emphasis, it's these other conditions that are really the greater risk for the youngest age groups. We do get some questions from facilities about what they're required to report. You are not required to report cases or outbreaks of COVID, flu, or RSV to the health department unless you're a healthcare provider administering a test. You are not required to report that to us. However, we would love to hear from you if you are experiencing a respiratory infectious disease outbreak at your facility. You are always welcome to contact us for information and support, strategizing. We have an online reporting form for non-COVID respiratory disease. We've got one for COVID as well forthcoming. And next slide, please. And just in terms of our expectations, again, we emphasized this a lot last year, but we don't want, COVID tests are not as available as they were. You don't need to factor that into your decision making. We don't, as a health department, we're not sort of imposing any required isolation periods anywhere. We want you to use the same principles with COVID as with other infectious respiratory diseases. If a child or staff member is too sick to participate, they shouldn't be there. And because mask use isn't recommended for children under 2 and may be difficult for some other young ones or individuals with disabilities, consider laying some of the other prevention strategies that we've learned in the last few years. And we'll go over those quickly on the next slide. But fortunately, a lot of what works with COVID, what folks have gotten more used to, wearing masks, things of that nature, are going to work to stem outbreaks of other conditions. So masking for those who can wear it, ventilation, hand hygiene and sanitation, vaccination, and staying home when sick as well. So those are kind of the high points from the health department. Do want to encourage you to, I've got contact on the next slide. I'm kind of here to say that, we are a source of information for you. We're a source of support. We want you to reach out to us with questions, concerns, logistics, and managing outbreaks. We're not imposing all the same requirements that we did in the height of the COVID pandemic, but we're still here. As Brina said, we're still here as a resource for you. And we value the work you do and we want to be a partner. So thank you.
Unmute.
Oh, sorry, back to me. So next we have Katie Mahiran. Is that how you say your name, Mahiran? To talk about immunization. Thanks for being here.
Yeah, thanks for having me. So while we're getting slides pulled up, I'll just go ahead and start introduction. My name's Katie, and I'm a nurse with the immunization program. And I'm going to talk to you a little bit about the influenza, COVID, and the RSV immunization products that are available. Next slide, please. Yep, and just here I do have some contact information later if you have questions. Next slide. So I'm going to start with the flu vaccine. Everyone 6 months and older should get it. Reiterating that message that everyone else has said. It's not too late to be vaccinated. We do have a public dashboard with some data on what our statewide rates are, and it's broken down by age. So that was updated Tuesday, and as of Tuesday, we've got 38% vaccinated for flu in the 0 to 4 years, and 33% in the 5 to 12 years vaccinated. So we really want to see those a lot higher, obviously. And when you're thinking about how you or people within the kiddos can access the flu vaccine, we're really suggesting access within pharmacies or providers' offices. For younger kids, I think probably more comfortable within the provider office, but it is available in the pharmacy for kids 3 years and older. You can get flu vaccinated at a pharmacy if you're 3 years or older. I just want to put a caveat that Medicaid will not cover the cost of the flu vaccine for anyone that's a child, so 3 to 18. So if you do have a family that has Medicaid, please make sure they're aware of that so they don't go and try to get vaccinated for flu and then told that they need to pay $100+ for the cost of the vaccine. But they should be able to access it at their provider office and not need to pay for the cost of the vaccine. And then, of course, we do have our district offices as a gap filler if there's an issue with someone not having a provider. Next slide. Okay, also COVID-19 vaccine recommendation for everyone to have the updated formula. We're starting to look at this more and more like the flu vaccine with an annual updated formula to match the variants that are current. But I will say there are some differences. The number of doses really depends on your age and the previous doses received based on which type you received. So if you got Pfizer or Moderna, but that is something that your provider or could all help sort for you with your recommendation. Again, not too late to be vaccinated. We're really seeing very low COVID vaccination numbers, 14% for both that 0 to 4 year age range and the 5 to 12 year age range. I will say that we're just not seeing the demand that there was earlier in the season. We did have some supply issues as the vaccine rolled out. This is the first year for commercialization. So the way that vaccine rolled out changed. During the COVID pandemic, the federal government paid for all COVID vaccines and distributed them at no cost. This is the first year where that's no longer happening. Instead, they're being paid for by insurance or some federal doses still for people that are eligible, but it's much more limited. So there were some supply issues as the commercialization happened and they were starting to get that product out just on a time frame that the manufacturing could happen and things like that. But we have no supply issues at this point in time. If there's anyone that's not vaccinated and wants to be vaccinated, they should not have trouble accessing. Provider offices have plenty of supply for kiddos. So again, access is in pharmacies and primary care offices. For the little kids, again, you want to refer them to the provider office. And for this one, it is slightly different. Again, it's 3 years and older that can be vaccinated in the pharmacy, but Medicaid will cover the cost of the COVID-19 vaccine in pharmacy. So if a family has Medicaid and they need COVID vaccine, the child 3 year and older could be vaccinated at the pharmacy and they won't have to pay for the cost of the vaccine. But if they need flu and COVID, it would just be easier to go to the provider office because you can get both on the same day and get them done and not have to worry about paying for one and not the other or making 2 separate appointments. Next slide. And I just put in a quick visual. I won't go into detail on this because again, providers are aware of this, can help guide families. But just what I was saying, that it really depends on your age, the number of doses you need, and what product they received in the past. Next slide. So the big change this year is we do have RSV products. This is the first year we've had RSV products available. In the past, there's been a monoclonal antibody product, that passive immunization for high-risk kids, but it's been really limited who can access it. So this is the first year where we've had what we call a universal recommendation, which means everyone should get it for infants. And the recommendation is for any infant 8-month and younger to receive the product. This visual just has the 3 different products that are all new this year. The one is the monoclonal antibody for infants. There's also the vaccine for pregnant individuals. And the purpose of that is to protect the infant being born. It's not about the pregnant person, it's about the infant and passing that protection on to them. And then we also do have the vaccine for adults 60 years and older. So if you have any staff, older staff, who are also at risk for having severe illness from RSV, then we would really recommend they talk to their provider about that vaccine. So as it was kind of alluded to, it's been a rocky rollout of the products, especially for those for infants. Next slide. So this nirsevimab is what this monoclonal antibody product is for infants. And like I said, it's a universal recommendation for 8 months and younger. So every infant 8 months and younger is recommended to get it. And then there's a select group of high-risk kiddos that are 8 to 19 months that should also receive. And those are the kids that have chronic lung disease, heart conditions, some specific risk factors. So that is who is recommended. In terms of access, we started off with it in provider offices because that was who was ready to administer it. And then we do have some in birthing hospitals now too. Supply has been limited. You can go next slide, please. So just being really upfront about what's going on, the manufacturer produced enough product for approximately 30% of the birth cohort. So when we say it's a universal recommendation, that's 100% of infants 8 months and younger should get it. Only enough product was produced for 30% of those infants nationwide. So they underestimated demand quite a bit. They based it off of some historic rollout of previous immunization products that had a different, I guess, impact on family day-to-day life, I think, and just times have changed. And so really underestimated it. It takes about 9 months to manufacture the product. So they can't just immediately catch up, recognizing that the demand has changed. It rolled out in early October and immediately the ordering was paused because they had already had more orders than they had supply. And that was true within Vermont and just nationwide. So at that time, CDC released prioritization recommendations that prioritized infants under 6 months and then the really high-risk kids under 8 months. This product does have, it's unique compared to most of our routine immunizations. It has different doses depending on weight, which is not true for routine immunizations. So it is a little bit more complicated in that you have to match a kid to the right product. And some of that is dependent on age, but for kids under 8 months, it's dependent upon weight. So what happened in Vermont is we had product come in, our orders were cut off. A lot of providers that tried to order had their orders denied and they or put on back order. We, as the immunization program, ended up looking at where the providers did receive product. We collected all of that product and redistributed it according to basically provider office population, the number of infants they saw within that age range. And then we've been trying to just push it whenever we can and move it back and forth based on need and really trying to follow those recommendations of prioritizing those younger kids. We have received a little bit more and we prioritize getting that into the birthing hospital so we can get those youngest kids. The birthing hospitals, some were ready to do it and some were not because it takes a lot of paperwork to get it all up and running. There's a lot of legal pieces, making sure things work within your electronic health record and just a lot of steps to add a new product. It really moved really quickly in terms of the rollout. So we luckily did get a lot of birthing hospitals ending up being able to take it this last, I guess, level of supply we got. We are being told by CDC that we should expect more product this month, but we don't know when. We don't know exactly how much. We anticipate it'll be quite a few, like it'll be a limited supply. We're still not going to get to having enough for, 60 or 80% of the birth cohort. It's going to be small numbers. We know that it's going to be something to kind of fill up a little bit of the empty pockets. So because CDC has identified additional product to roll out nationwide, they went ahead last week and rescinded those prioritization recommendations. And just also because the virus activity has really increased. And so the push is just get everybody immunized that could be immunized and bring down that pressure off of the healthcare system. And hopefully if we can immunize the kiddo that's 7 months with the product, then there's more capacity to deal with the 4-month kiddo that for some reason was not getting that product. So of course we're still really leaving it up to providers on how they prioritize infants within their practice, because they have the supply, but we're asking them to immunize everyone right now and not hold any product. We don't want any products left. Next slide. So the other option for how we can wrap around and support these infants is by this RSV vaccine for pregnant individuals. So if someone is pregnant, they can receive this vaccine within 32 to 36 weeks gestation up until January 31st. So we only have a couple more weeks until it's no longer allowed to be administered. And the reason for that is because the CDC decision-making body, which is called ACIP, that makes recommendations for immunizations, looked at how long it takes for protection to kick in after the pregnant person is immunized, and then that time span for the infant to be born, and looking at the seasonality of this virus. So the thought is that if someone is 36 weeks pregnant, they receive the immunization full term, hopefully they make it to 40 weeks, then the child should hopefully be born with outside of the peak of RSV season. It's really the thought process behind that. Again, there have been a little bit of a different supply rollout with this. I'm not going to go into great detail, but we are what's called a universal purchase state. So providers receive a lot of their vaccine supply directly through the state because insurers pay in. And CDC has been pretty slow to add this vaccine onto their contract, so it hasn't been available for purchase and available for ordering for the providers who receive that state supply. And a lot of providers don't have built into their budgets to private purchase because it's quite pricey, and without a lot of forehand knowledge about how to budget that, they just haven't. And waiting on the state supply, which is normal. So it is available in pharmacies. We have data specifically on the pharmacies I have listed that have administered. And so these pharmacies in various parts of the state, obviously a lot are in Chittenden County, but there are some throughout other parts of the state as well. We have heard that some individuals have been turned away when they go to the pharmacy. It's really important to recognize that there are actually 2 RSV vaccines. Only one of them can be given to pregnant people, and it's called Abrysvo, and it's the Pfizer vaccine. The other RSV vaccine, which is called Arexvy, cannot be given to pregnant individuals. It's only for older adults. So the pharmacy has to have the right vaccine. They might only be carrying the one for older adults. And then there are potentially some prior authorization issues, but for Medicaid, they do require prior authorization for pregnant people when they go to the pharmacy, but the pharmacist should be able to walk someone through that. And if not, a provider can help with some case management around that. It shouldn't be a big barrier. So if someone a family has Medicaid, goes to the pharmacy and tries to get this vaccine and runs into some issues, really recommend reaching out to your provider immediately to get help on navigating that, because that should not be the barrier. Private insurers can also require prior authorization, and also they have up to 12 months to actually cover the cost of the vaccine and for after it's recommended. So some private insurers may not be covering it this year. So really recommending that families work with their providers to identify best way to access. Next slide. I just included this here for reference. Really outlines the different products and the specific timelines on when they can be administered. Next slide. And that's it.
Thank you so much. I think I don't see any questions in the chat so far, unless I'm seeing just the speakers chat. I'm not seeing any questions specifically. I just want to thank you so much, our presenters so far, and just reinforcing sort of their message around the basic public health pieces that we all know. So you're encouraging your staff and your families to get the immunizations, to perform the hand sanitation, to wear masks when they're able to, stay home when they're sick. You know, it's just continuing with that sort of basic respiratory all those lessons we learned in the last few years, and knowing your role is to encourage your families around vaccination. You know, we learned a lot from Katie, and it's great to know sort of the complexity sometimes of like why things are available and why they're not, and to help support families in just, you know, keep trying, right? It's okay, you might not be able to get it now. If you hear them talking about it, okay, try again, talk to your provider, you know, just keep working on those pieces. And that's kind of the child care provider role, right? Is to help support your families just to follow some of these recommendations. And I see Becca with her hand up.
Thanks, Katie. I actually have to run, but I just, as a last word to this group, is that this is a very frustrating RSV season because these products are available, but there just isn't enough for people. And so it's extremely frustrating for me personally, because it's like been a really tough season. It's very busy. It's hard for these families sometimes who are in the ICU saying, I really wanted this for my child and couldn't get it. There's lots of other families who never even don't even know that these things exist either, who so what I would like to just do is, like, the way to get through such a frustrating period is to think about, like, I think there's a light though, you know, like showing those graphs in the RSV season. It's been the same my entire career. It's always terrible. It's always bad. I think we can make future seasons better, more palatable, better for kids and better for families. And we would love your help with this. So I am already starting to think about, especially once we get more product available, like next season, when we've got the maternal vaccine, we've got the Nirsevimab for infants, like how you all, and you have the target audience, right? You've got the truly the babies being born to the toddler siblings. Those are the kids that end up in the ICU. So like, would love to think about how we can all partner together about disseminating information. And we want to start probably doing it in the fall. So email Luann, and like she'll get this group together and we can start thinking about what's the best way to disseminate information to your communities about this and about these products and about RSV. So I think it's a super frustrating season. We're at the peak. We're gonna have RSV for 2 more months at least. You know, the post-viral cough lasts for 3 weeks. People are gonna be coughing and sick for the next like 3 to 4 months. It's hard, but let's like gear up for next season and see what we can do together as a group. And I have to run, but it's nice seeing everyone again.
Thank you so much, Becca. Yeah, there is one question I wonder if maybe if you have to go, maybe Brina can tackle it. So I don't know.
Yeah, I can tackle that. I think, well, first of all, I love Becca's, she just rattled off some very important information, so I'll just repeat it, which is that the question in the chat about how long you have to be out in childcare. So it's all about symptom, you know, abatement, making sure the kids are back to their wellness as it relates to their ability to participate in your program. And you all taught me that like 3 years ago, that this idea that a medical provider would sign off and say, the kid's fine, go back. And then by 9 a.m. that he's lying on his mat, not with the energy needed. That's what matters here. So unlike COVID, where we developed all this strict, like day 0, day 5, put the mask on. Things like RSV, it's all about, is the kid no longer have a fever, back to his normal or her normal activity. But this post-viral cough is going to last for several weeks. So you're not going to be able to use cough as an indicator of keeping kids out, or otherwise they'll be out for the rest of the winter. And I'm sure you've had that experience. And it puts a lot of, it's very important that you feel that teaming with the parent, and we remain committed to you. If you hear there are pediatricians like before that are saying these kids are fine, just go back to childcare, without understanding your system or the impact on your program, we need to know about that. That's a great role for Katie and Brina. We like to just remind people the importance of teams and communities in the care of children. So I'm sure right now you have kids right underfoot that are coughing, but well, because every meeting I go to, people are still coughing. My husband's been coughing since November. I'm starting to wish it was different.
Yeah, and I've got a child at home whose nose has been running for months, it feels like. I just really quickly as well wanted to offer a very minimal update on the whole COVID test kit access piece, just to let you guys all know that the Department of Health has officially distributed all their test kits. So we are out. I know the schools were still kind of getting a few and things like that. So and the schools testing forms they're being redirected to federal test kit access. So that's that piece. And as far as the general public, we do have links on our website. I'll put these in the chat and you'll get these afterwards as well, in some of the materials we'll send out. This is our general test kit site, and then this is the federal site here for ordering. So if you have families that want to order test kits, they can order them through the federal government and get some COVID test kits out there. So just so you know, that's officially over. And there you may see some schools might have a reserve still, or some of your community partners, like there might be some floating out there that are available for the public, but the Department of Health has now distributed all their test kits, so they are out. And I'm not seeing any more questions in the chat, so I can just quickly, if people are interested, we have a few more resources that are not necessarily illness related to share as well.
Katie, before we go on to that, could I make a couple points?
Yep.
One is that I wanted to ask if either you or Brina wanted to talk about, I know what's on the minds of many of the program leaders that I work with is not only are their children not well, but their staff are not well. And again, balancing that. And I know it's the same answer, it's the same if they're well enough to be there and all of that. But you folks are so good at sort of putting a bow around kind of an approach to helping programs manage keeping their staff healthy. And I didn't know if you wanted to talk about that a bit, Brina.
Well, I can just add that so what we experienced in Vermont is true around the country, which is that there was so much isolation, not the official COVID isolation, but people really attended to their respiratory health for several years. And then the lifting of that and people trying to get back to their connecting has led to massive holiday spikes in from Thanksgiving and the Christmas holidays in the viral load in this state. So we can't really ask people to go back to the general concept of isolation, but what we really have to keep reinforcing for ourselves is we have to attend to our symptoms. And if we're not feeling well, we have to stay home. Because I think what happens is somebody feels kind of okay, goes out to a family event, and then everybody gets sick, not necessarily COVID. So I'm so curious. Obviously, John reminded us, I think people are pretty good at hand washing. I see much better hygiene around coughing and really stepping out and knowing that nobody really wants to be near someone coughing. I think the masking piece is variable. I really would appreciate if people would mask more when they were not feeling great, not for COVID, just that we put that into our societal norms. Why can't we keep it? And, as Becca pointed out early on, we really saw healthier kids when people were not running around with other respiratory viruses. So it's just dialogue about making sure we attend to our symptoms and not expose each other. I've had some really interesting conversations about this because people aren't doing that. And I don't know, as directors and as childcare leaders, how to have that conversation with staff, because you want them, to continue to enjoy their personal lives, but also not put the other staff and children at risk. So it's just relationship based and understanding how complicated our world is. But I really do know that people go back to work in your field sooner than they feel well because they're incredibly committed to their jobs.
Mhm.
And I wish there was a way to not have that happen, but I also know you don't have substitutes and a lot of other choices. So it feels case by case and relational to me. And while I'm unmuted, I did want to, Becca reminded me by text after she departed that, RSV, she really hammered home the point. That's a very significant illness for teeny babies. But a 2-year-old with RSV it's a cold. So if you have kids among you who have RSV, you don't have to rush them for testing or to their primary care. That isn't it's not like COVID where we need to know the name of the virus. I mean, certainly the health department likes the surveillance of knowing the RSV out there, but they have other ways of doing that. So I just don't want you to feel like your job is to drive everyone toward RSV testing, because it doesn't change anything about the management. It's just a cold in older kids. It's a fascinating virus because the thing that puts you on a ventilator as an infant is not the respiratory congestion and the cough. You actually stop breathing. It's called apnea. There's something about this virus in our teeny littlest that causes them to just halt. They just breathe in and they stop. And it's super frightening. So it's not the severity of the respiratory stuff. Do you know what I mean?
Mhm.
Just important that we know. I just remember being so frightened of RSV when you work in a hospital and then you get out in the community, you're like, oh, it's a cold. It just has a name.
Well, and the other point that I wanted to bring up that you made earlier that I think is so important is when you mentioned maybe making a plan for how to communicate this next fall before we're in the middle of this. And one of the things, and it's related to what you just said also, and that is so much of this is relationship building and relationships. And so the more programs can communicate next fall with parents around what we expect is going to be coming, because this is what we've heard from our partners at the health department and at the hospital. I think that whole relationship building piece is such a key piece of this. And so I love your idea of sort of having a focused discussion around this early next year to help these programs through their newsletters, through their day-to-day conversations, through their parent conferences, just communicate what the plan will be so that the parents can prepare to keep their kids home when they can bring them back, and that whole piece. So
Right.
I love that piece. Thank you.
Well, and the opportunity to partner with your local medical homes and pediatricians, that's been there've been some real bright spots to that during the pandemic. And I know in some communities, it's still a really nice connection. So thinking about that together. And then I do want to pick up on something that Katie, our immunization Katie, said, which the demand for this RSV shot was actually quite significant. And as you can see, the debacle of the national supply has really upset many of us. But right below that is kind of an encouraging, so families wanted this. And it didn't fall into it's not really a vaccine, as you know, it's a monoclonal antibody. So, but when we get new vaccines in our society, it takes a while to get them sort of, families in a space of stepping up for that. And this one, everyone's like, I know that virus set me back 6 weeks. So I think when we have the adequate supply, you are going to have healthier environments. Becca was being very helpful, hopeful that the uptake from your families for this shot will be good if we could just get the supply right. And, for those little babies. And also your help in that is always so terrific. Like, I thought today we gave you a lot of really detailed information because we've been struggling so much with everybody keeps promoting something that doesn't even exist as a supply, like, or go get your flu shot at the pharmacy. Oops, not if you have Medicaid. Like it's hard enough to be on this earth without all of the complexity that we layer. So teaming up with you guys in like September to just get ready and to have shared messaging and to offer us as a resource to you and your families is our commitment. We really want to do that.
Thank you so much. That's great. I think the resources that I have to share around safe sleep, I'm just going to include them in the resources we send out afterwards, just to let you guys know what they are is just that we, with the child fatality review teams who reviews deaths to children, there were some unsafe sleep environment deaths with infants and that were very unfortunate. So they created a safe sleep committee, which Becca Bell is on as well, and created some new brochures to hand out to families. So there's one on sort of child development, sort of what to expect with sleeping. There's one on a safe sleep environment. And there's also one on products to avoid for infants. So I think that one will be, very helpful for you as well. But all three of them are on our website. We will send you the links to those as well. The American Academy of Pediatrics has a parent handout on safe sleep for infants with illness. So that's another great one for families and for you as well. Another link to that one. And then the other resources we've been seeing in multiple cases in different regions around counterfeit car seats, which is very scary.
Oh,
And that is typically they're purchased through Amazon through a third party, seller. And so they are not real car seats. They don't have any of the same stickers and they are not safe. And so we have some resources around that as well that we'll send out just in case you're talking to families. Just say, hey, when you're purchasing, if you have a family with a new baby coming on and they're buying stuff for their babies, just be really careful about what you're buying because that's a scary thing. And they don't go through all the testing and all the same level that other car seats do. So that's really not a thing we want to see. And parents can't leave the hospital with those car seats. So if they get caught at the hospital by the car seat technician, they can't go home until they get a new car seat. And that's we don't want any families in that position as well. So I'm going to send out those resources afterwards.
Thank you so much, Katie and Brina and the rest of the team. And of course, to Becca, who had to run. And in response to Amy's question earlier on, the information about these calls typically is on the Let's Grow Kids Facebook pages and also often attached to one of the Sherry Carlson emails that goes out. So we try to just put the information of the upcoming dates out there. These have been, since we got through COVID, we moved these to just seasonal, and there will be one in the spring. We'll be being in touch with you around who's hosting it and when it will be. And again, thank you all, especially thank you to the health folks, experts. This is so helpful for folks who are communicating with parents, and to you early childhood people. Thanks for taking the time. Hope you have a nice afternoon. Thanks, everybody.